Let's delve into the management of superior semicircular canal dehiscence syndrome, or SSCD, a condition that can significantly impact a patient's quality of life through symptoms like vertigo, oscillopsia, and autophony. Today, we'll cover 3 key management strategies: ventilation tube insertion, superior semicircular canal, SSC, capping/resurfacing and plugging, and round window reinforcement. First, ventilation tube insertion. While not a definitive treatment for SSCD, this minimally invasive approach can help alleviate symptoms, particularly in patients with concurrent Eustachian tube dysfunction. By stabilizing middle ear pressure, ventilation tubes can reduce the severity of pressure-induced vertigo and other vestibular symptoms. It's often used as an adjunct therapy or for patients not ready for more invasive surgical options. Moving on to the more definitive surgical interventions: SSC capping, resurfacing, and plugging. These procedures aim to physically reinforce or obliterate the dehiscent canal. Let's break this down by approach. The endoscopic approach. This minimally invasive technique allows for direct visualization and access to the dehiscent canal through a transmastoid route. Using this approach, the surgeon can precisely place materials like bone pate, cartilage, or fascia over the dehiscence, capping or resurfacing, or they may opt to completely obliterate the canal with bone and soft tissue plugging. The middle cranial fossa, MCF, approach. This traditional approach involves a craniotomy, providing superior access to the canal through the temporal bone. It allows for direct visualization and meticulous repair of the dehiscence. Surgeons often prefer this method when there is significant bone erosion or in cases requiring complex repairs. The mastoid approach. This transmastoid technique is less invasive than MCF but provides limited access compared to the endoscopic or MCF approaches. It's particularly useful for plugging procedures, where the surgeon can access the superior canal through the mastoid bone and use autologous or synthetic materials to close the canal. Next, round window reinforcement. This technique addresses the abnormal transmission of sound energy through the inner ear by reinforcing the round window membrane. Materials like fascia, gel foam, or collagen matrix are placed over the round window to dampen the abnormal vestibular responses. Round window reinforcement is often used in combination with other surgical techniques to enhance symptom relief, particularly for patients with severe hyperacusis or sound-induced vertigo. Each of these interventions has its indications, benefits, and potential complications. Ventilation tube insertion is less invasive, but may provide only partial symptom relief. SSC capping, resurfacing, and plugging are more definitive but come with surgical risks, such as hearing loss or dizziness. Round window reinforcement serves as a useful adjunct, particularly for patients with persistent sound-induced symptoms. The choice of treatment depends on various factors, including the severity of symptoms, patient preferences, and anatomical considerations. Preoperative imaging, particularly high-resolution CT scans, is crucial for surgical planning and determining the extent of dehiscence. In summary, managing SSCD involves a tailored approach, balancing symptom relief with the risks of each intervention. Ongoing research and advancements in surgical techniques continue to refine these procedures, offering hope for improved outcomes for patients with this challenging condition.